of the INICET. The previous INICET questions. So I'll be discussing today here. So let me start with the first question here of the May 2023 paper, INICET paper. Here the question says that 32-year-old patient presents with a dermatology clinic with a recurrent facial swelling. That means patient has some skin lesion. That is why patient has gone to a dermatology clinic. Okay. Now, here dermatology clinic with a recurrent facial swelling, especially of the lips. The patient reports that these episodes have occurred intermittently over the past several years. Facial swelling, particularly lips. Along with the facial swelling, the patient also has fissured tongue. So patient is having lip swelling. That is the one thing we have to notice here. Patient is having lip swelling. Patient is having lip swelling. Okay. Then patient is having the fissured tongue, and the patient is having the granulomatous swelling, that exact particularly of the lips, that is called as cheilitis granulomatosa. So if you see combination of these three things in any patient, lip swelling, facial fissured tongue, and cheilitis granulomatosa, typically the diagnosis, what is the most probable diagnosis? You can see here patient is having a lip swelling here classically, and the patient is having a fissured tongue. Okay, and the patient will have cheilitis granulomatosa, facial swelling. Exactly, the diagnosis is Melkersen-Rosenthal syndrome. So this triad is very important. This is a very frequently asked basic question. Triad of Melkersen-Rosenthal syndrome. What is the triad of Melkersen-Rosenthal syndrome? The facial swelling, cheilitis granulomatosa, and the fissured tongue. So you have to remember the fissured tongue. Usually they give options, some other options like the median rhomboid glossitis or hairy tongue, something like that. Don't get confused. It is fissured tongue. Okay. Moving, explanation is simple, like Melkersen-Rosenthal syndrome is a rare mucocutaneous disorder characterized by classic triad of the recurrent facial swelling, relapsing facial paralysis, fissured tongue. Okay, that is what is there. Usually all the three will not be there. Usually all the three will not be seen in most of the patients. Most of the patients, usually they will have one or two of these features. Okay, so the granulomatous swelling of the face or lips is a distinguishing feature of this condition. This is very important. So granulomatous swelling is the most important point in this particular condition. Granulomatous swelling we will be seen in the face or the lips. Okay, that is important. Now moving on to the second question here. 28-year-old patient presents to a neurology clinic with a complaint of intermittent facial motor seizures. The patient is having seizures involving the contralateral hand and forearm. Physical examination reveals a linear depression on the forehead, like a sword basically. And the patient complains of pain along the trigeminal nerve. So patient is having basically a midline depression, forehead. Typically, if you see this patient, this is the case where you can see classically a linear depression on the forehead. This is called as a Kaup de Saber. What is this depression on the center of the forehead called as? It is called as Kaup de Saber. What is Kaup de Saber? It is the linear depression on the center of the forehead. On the center of the forehead. Okay, so this linear depression, Kaup de Saber, is a class, and the patient is having, this is one more important point, see here, and the patient is having atrophy on one half of the face. You can see one half of the face entirely there is atrophy. The classic diagnosis is Parry-Romberg syndrome. Parry-Romberg syndrome is also known as hemifacial atrophy. Hemifacial atrophy. So hemifacial atrophy is a condition in which one half of the face, entire face, skin, muscles, bone, teeth, even teeth are also small. The teeth, for example, patient is having right side Parry-Romberg syndrome, right side the teeth will be small compared to left side. Bone will be small, maxilla, mandible, skin will be very thin, muscles will be atrophic. So that is what is a hemifacial atrophy. See, the Kaup de Saber is also seen in linear scleroderma. Don't get confused, linear scleroderma. So you have to find out that clue, atrophy. In scleroderma, you don't see that unilateral atrophy, whereas in case of Parry-Romberg syndrome, you will see unilateral atrophy. Very good, great. Most of you are participating in the this one answers. Very happy. So any doubts you can ask me. We will discuss. Parry-Romberg syndrome is also called as progressive. See, this is important. Word is progressive. That means the atrophy doesn't stop. It continues. It is progressive. It goes on increasing. Initially, it might involve the just skin. Later, it goes on involving deeper structures. Deeper structures. So it is slowly atrophying. With that slowly atrophy, the patient develops the midline depression on the forehead. That is called as Kaup de Saber or sword-like. Sword-like. Okay. Typically, these patients have got neurological manifestation, particularly called as Jacksonian epilepsy. This is very important. Please remember. They will have some neurological manifestations. Please remember. Scleroderma patients doesn't have neurological manifestation. Parry-Romberg syndrome will have the, see why I am coming scleroderma. Even in scleroderma, why I am comparing with scleroderma, because scleroderma patients also will have a linear depression on the forehead. Parry-Romberg patients also will have linear depression on the forehead, but Parry-Romberg patients will have Jacksonian epilepsy, as well as they will have trigeminal neuralgia, which you don't see in case of the scleroderma. Okay, this is the point you have to remember, all of you. Okay, next, moving on to the third question. The image below has a characteristic feature which is peculiar to all of you. Can classically diagnose this. You can see here so many depressions are there. All are punched out depressions. This is called as punched out radiolucencies. This is known as punched out radiolucency. Typically, punched out radiolucency is seen in case of multiple myeloma. Multiple myeloma. Okay. In case of there is one more condition where you can see such punched out radiolucencies, particularly in case of early Paget's disease also. In case of early Paget's disease of bone, there also you can see this punched out. Instead of punched out radiolucency, there they call it as osteoporosis circumscripta. Osteoporosis circumscripta. Okay, please remember this. There is a lot of difference. In multiple myeloma, you are going to call it as punched out radiolucencies. There also it is same, punched out radiolucencies only. But in early Paget's disease of bone, in the skull, you will see osteoporosis circumscripta. Osteoporosis circumscriptum. Okay, great, all of you, great. Okay, um, consider the following tumors: odontogenic fibroma, odontogenic myxoma, cementoblastoma, AOT. Which of the following tumors develop from odontogenic mesenchyme origin? So we have seen the classification of odontogenic tumors. Some are purely epithelial in origin, some are purely mesenchymal in origin, some are mixed. Okay, in odontogenic tumors. So here the question they are asking is, there are 4 tumors, 3 are purely mesenchymal. They don't have any epithelial component. We know that this is an epithelial. AOT is epithelial. What are the other epithelial? Ameloblastoma, AOT, CEOT, and SOT. SOT is squamous odontogenic tumor. So we have ameloblastoma, we have AOT, we have CEOT, that is calcifying epithelial odontogenic tumor, and SOT, squamous odontogenic tumor, which are purely epithelial. The other 3 are, which are nothing but your classically the purely mesenchymal in origin. So the correct answer here is 1, 2, 3. So this is the one which is purely odontogenic epithelial in origin, which is purely odontogenic epithelial in origin. Okay, so this is what you are supposed to remember about the this particular MCQ. Magenta tongue is evident in. So magenta tongue is typically that is a magenta colored tongue. You have to remember classically the riboflavin deficiency. Riboflavin deficiency. This is again a simple question. There's nothing much to discuss here. One thing you have to remember is niacin deficiency, which causes pellagra. And you in pellagra you see bald tongue of sandwich. In pellagra you see basically bald tongue of sandwich. Please remember this classically, bald tongue of sandwich. So magenta colored tongue is a classical feature of riboflavin deficiency. Riboflavin deficiency. So I hope this is again a classical MCQ. Sandwich. Where do you see bald tongue of sandwich? Okay, that typically you see in case of the typically in case of niacin deficiency, which causes pellagra. Okay, here just to deviate slightly, where do you see the Hunter's glossitis? Anybody can answer to this question? Hunter's or Moller's glossitis? Any answer to this? Please let me know. Please participate in this. Where do you see Hunter's or Moller's glossitis? Where do you see? Castle necklace, definitely, very good. Castle necklace is seen in pellagra, fine. Where do you see Hunter's or Moller's glossitis? Any answer for this? Anybody can type it. Yes, vitamin B12 deficiency. Particularly, which type of anemia do we call it as? We see typically this in case of pernicious anemia. Not exactly all types of vitamin B12 deficiency, but it is broadly right that you see this in pernicious anemia, Hunter's or Moller's glossitis. So you have supposed to remember these names. Hunter's or Moller's glossitis is seen in. Bald tongue of sandwich is seen in. Okay, all these things you have to supposed to remember. Okay, moving on to the next question. Infectious mononucleosis is caused by. Okay, basically infectious mononucleosis is a viral infection classically caused by Epstein-Barr virus. Epstein-Barr virus. So let us make some lesions which are caused by Epstein-Barr virus. Epstein-Barr virus typically causes oral hairy leukoplakia. Oral hairy leukoplakia. All of us know that this is a very important oral manifestation in HIV positive patients. Oral hairy leukoplakia, right? So in oral hairy leukoplakia you will see the it is caused by EBV. Then infectious mononucleosis is caused by EBV. Okay, then non-Hodgkin lymphoma. Non-Hodgkin lymphoma is caused by EBV. Nasopharyngeal carcinoma, very good. Nasopharyngeal carcinoma is caused by EBV. Non-Hodgkin lymphoma, nasopharyngeal carcinoma is caused. Even in non-Hodgkin lymphoma, particularly called as Burkitt's, there is a type of non-Hodgkin's called as Burkitt's also is caused by EBV. So you have to remember that these are some important conditions which are caused by Epstein-Barr virus, like oral hairy leukoplakia, infectious mononucleosis, non-Hodgkin's lymphoma. Broadly, type of non-Hodgkin's lymphoma called as Burkitt's is also caused by EBV, Epstein-Barr virus, and there is also called as nasopharyngeal carcinoma. Please remember, Hodgkin's lymphoma has got no much association with that of the EBV. Please remember that. The most common oral lesion seen in HIV positive patients. So in HIV positive patients, there is one classification called as EC clearinghouse classification. So you are supposed to remember this name of this classification, EC clearinghouse. According to EC clearinghouse classification, there are 3 groups of oral manifestations in HIV positive lesions which are most commonly seen. So among those lesions, the most common that is the oral candidiasis. So oral candidiasis is the most common oral manifestation that you see in case of HIV positive patients. However, if they ask you the most common, or which you can call it as the AIDS defining neoplasm, that is called as Kaposi sarcoma. AIDS defining neoplasm. So what is AIDS defining neoplasm? It is nothing but a neoplasm which, if you see, definitely you are sure you can diagnose that this patient is HIV positive. This patient is HIV positive. So the Kaposi sarcoma is called as AIDS defining neoplasm. However, there are other oral manifestations. So ANAG is also oral manifestation. ANAG is acute necrotizing ulcerative gingivitis. Even linear gingival erythema is also an oral manifestation of the AIDS patient. But the most common is oral candidiasis. Cleft lip and cleft palate is associated with all except. So there are 4 syndromes which are given here. One which is not associated with the cleft lip, cleft palate, we are supposed to identify it. So Van der Waals syndrome, yes, it is associated. Gardner syndrome, no. Popliteal-Pterygian syndrome, yes. Pierre-Robin syndrome, yes. So Gardner syndrome is not associated with cleft lip and cleft palate. Please remember this, Gardner syndrome. So Gardner syndrome basically is associated with osteomas of the jaws. They are associated with the osteomas of the jaws. They are associated with the supernumerary teeth. They are associated with the supernumerary teeth. They are associated with the multiple dentigerous cyst. Multiple dentigerous cyst. Okay, so these are the things that you are supposed to remember, that the Gardner syndrome is associated with osteomas of the jaws, supernumerary teeth, and multiple dentigerous cyst. All other are typically associated with the cleft lip and cleft palate. Okay. Now, moving on to the 10th question here. The causative organism for, yes, multiple polyposis definitely seen, but we are talking of there is a comment that in Gardner's multiple polyposis seen. Yes, we are commenting right now. We are discussing here about the oral manifestation. Definitely you are right. Okay, thumbs up that you can even see the sebaceous cyst or epidermoid cyst in Gardner syndrome. Okay, good. Causative organism of herpetic gingivostomatitis is classically HSV1. So HSV1 is nothing but herpes simplex virus 1, which is also known as human herpes virus 1, HHV1. HHV1 is nothing but HSV1, whereas HSV2, herpes simplex virus 2, which is HSV2, causes basically the herpes in the genital areas. Oral herpes is mainly caused by HSV1. So we should know that the oral herpes is of primary and secondary. Primary is for the first time when the patient is getting the herpes. It's an acute condition where it is caused by HSV1. Again, secondary, that is the latent, once the or recurrent. After some time, again it recurs, herpes, that is called as a recurrent herpes gevostomatitis, recurrent herpes labialis, where that recurrent herpes labialis is nothing but caused by basically the again HSV only. There the patient will have basically the lip swelling. That is why it's called as herpes labialis. Herpes labialis. Okay. Moving on to the next question here. The features of oral tuberculosis are all except. So when we are talking about oral tuberculosis, the patient definitely has got weight loss. Yes. Patient definitely has got night sweats. Yes. Patient has got painless ulcer. No. Painful ulcer. Remember, TB ulcer is a painful ulcer. Patient definitely has got mild fever. Remember some important oral ulcers which are painful, like aphthous ulcer, if you take, is basically painful ulcer. Okay. TB ulcer is basically a painful ulcer. Then herpetic ulcers, herpes ulcers are basically painful ulcers. And even traumatic ulcers are basically painful ulcers. Okay, traumatic ulcers, painful. Painless ulcers are your painless ulcers are classically the syphilitic ulcers are painless ulcers. Okay, syphilitic ulcers are painless, and malignant ulcers are painless. Please remember, malignant ulcers are usually painless, because what happens is those malignant cells, it will go and destroy all the nerve endings. So patient who is having a malignant ulcer will not perceive pain. That is because the free nerve endings are easily destroyed. Okay. Next question. Intraepithelial clefting is seen in. Intraepithelial clefting is seen in basically pemphigus. Pemphigoid has got subepithelial clefting. So if you see here, option 1 and 2, that is the pemphigus vulgaris and paraneoplastic pemphigus. Remember, paraneoplastic pemphigus is the one which is associated with the neoplasm. Usually it is associated with NHL, non-Hodgkin's lymphoma. Okay, it is associated with non-Hodgkin lymphoma, paraneoplastic pemphigus. And this paraneoplastic pemphigus, which is associated with non-Hodgkin lymphoma, has got both intraepithelial IEC, intraepithelial cleft, as well as SEC, subepithelial cleft. Please remember, paraneoplastic pemphigus is the one which has got both the clefts, intraepithelial clefting also, subepithelial clefting also. Okay, let us move to the next question. Nikolsky sign is negative in, it's a simple thing. Remember, Nikolsky sign is always negative in pemphigoid, particularly in bullous pemphigoid. In cicatricial pemphigoid, there are pemphigoids of two types: cicatricial, bullous. Cicatricial is the one which involves the mucosa. Bullous is the one which involves the skin. Remember, the one which involves the skin, that is bullous pemphigoid, will have Nikolsky sign negativity. It is not seen. So what is Nikolsky sign? Just to refresh, Nikolsky sign is nothing but loss of the epithelium or peeling of the epithelium on applying tangential pressure on the skin around the lesion. Wherever the lesion is there on the normal skin, around that, if you apply tangential pressure, there will be peeling off of the skin. That is called as Nikolsky's sign. So Nikolsky sign positivity is seen in pemphigus. It is seen in all other conditions. Pemphigoid, you don't see Nikolsky sign positivity. Bullous pemphigoid particularly. Okay. A tumor which is characterized by spontaneous involution in child diagnosis would be? So here the question say is spontaneous involution. That means you need not treat anything here. You need not give any treatment. It's simple like hemangioma. Hemangioma does not require any particular this one. Most of it will involute on its own. Lymphomas, no, lymphomas are malignancies. They won't show spontaneous involution. Involution means on its own regression. Squamous melanoma, no, melanomas also don't involute on its own. Abscess, definitely treatment is required for abscess. Definitely treatment is required for abscess. So hemangiomas are the one which will involute on its own, spontaneous involution. Consider the following: Fox, calcified Fox cerebri, OKC, rib anomalies, enlarged mandible, syndactyly. Which of the following are nothing but the features of the nevoid basal cell carcinoma syndrome are not seen? So they are not seen. So which is not seen? Which is not seen basically? If you see, enlarged mandible and syndactyly are not seen. All other three are seen. Yes, we see calcified Fox cerebri in the midline. We see multiple OKCs in nevoid basal cell carcinoma. We see rib anomalies. Enlarged mandible, the syndactyly are not a features of the basically the nevoid basal cell carcinoma syndrome. So what is nevoid basal cell carcinoma syndrome? It is also known as basically Gorlin-Gotts syndrome. Gorlin-Gotts syndrome, where in this Gorlin-Gotts syndrome, the patients will have basically multiple OKCs. The patient will have basically the multiple OKCs. Multiple OKC. Okay, please remember here there is nothing to do with the syndactyly. There is nothing to do with the syndactyly. What is syndactyly? Syndactyly is nothing but fusion of the digits or fusion of the fingers. So this syndactyly is typically seen in patients of Apert syndrome. Typically in patients of Apert syndrome, we will see this the upper syndactyly. Okay, this is what is your nevoid basal cell carcinoma syndrome or NBCC. Okay, great. Now let us move on to the next question. Which of the following pathologies cannot be a differential diagnosis of a radio opaque structure present in the path of eruption of maxillary anterior tooth seen in OPG? The seen in OPG. So basically, pathology cannot be a differential diagnosis on radio. So usually in maxillary anterior teeth, you can see many things, but not the complex odontome. Remember, complex odontome is not seen in maxillary anterior, but it is seen in posterior mandible. Posterior mandible. So that is the answer, that complex odontomes are not seen in case of the maxillary. So here the question is maxillary anterior tooth region, radio opaque structure. Yes, compound odontome definitely will come. Supernumerary tooth definitely will come. Unresolved primary tooth roots definitely will come. Complex odontome usually doesn't, first of all, complex odontome doesn't resemble any tooth-like structure. It doesn't resemble anything like tooth-like structure basically. And usually complex odontomes are seen in case of posterior mandible. Compound odontomes are seen in maxillary anterior tooth. Maxillary anterior tooth. Okay, usually this compound odontome are made up of denticles, small radio opaque structures which look like teeth. So if you see, there will be small structures which look like teeth, and this particular appearance, radiographic appearance, is called as bag of worm appearance. Where do you see bag of worm appearance? Bag of worm appearance on radiograph. This is the radiographic appearance, radiographic feature of particularly the compound odontome. Compound odontome. Okay, please remember compound odontome has got a radiographic feature called as a bag of worm. This is a classical MCQ that is very frequently asked. Where do you see bag of worm appearance? Bag of worm is a radiographic feature of compound odontome where multiple small radiographic structures, radio opacities are seen in the anterior maxilla. Seen in the anterior maxilla. Okay, moving on to the next question. A 60-year-old smoker had pain and swelling over his right cheek region. His histopathology is attached for your reference. Best diagnosis would be. So if you see here, the patient is having a cheek swelling. That means it is some salivary gland swelling. Patient is basically a smoker and patient is having swelling. And if you see classically, there are lymphocytes. All these are nothing but lymphocytic areas. And if you see carefully here, there is a epithelium which is bilayered. It is bilayered. If you can classically see here, the epithelium is something like this. Classically seen, bilayered. That is called as papillary epithelium. And if you see here, there are certain cystic structures here. So cyst adenoma. So if you see papillary cyst adenoma lymphomatosum, that is nothing but your classically Warden's tumor. So this image is a very classical image based question that you are supposed to remember. So they have just asked, they have just given a history that patient is having a swelling in the cheek region. So cheek region means salivary gland obviously, and the patient, if you see histopathology, classically you will be able to see lymphocytes, you will be able to see papillary cystadenoma, that is papillary layer, bilayered epithelium, and cystic space which are filled with the eosinophilic coagulum. Okay, great. So that is what is your Warden's tumor. That is why the name is also given papillary cystadenoma lymphomatosum. It is also known as adenolymphoma. Please remember, it is also known as adenolymphoma. Remember, this adenolymphoma name is actually a misnomer. Is actually a misnomer. It should not be used for Warden's tumor because it is not lymphoma. It is a salivary gland tumor, salivary gland benign tumor, particularly benign neoplasm. Okay, and one more thing, they have given history of smoking. Remember, they have found out smoking as one of the etiology for Warden's. So whenever they talk about etiology of Warden's, remember two things. Smoking is the one, and another one that is associated with the is radiation. Smoking is the one, and another one is the radiation, which is seen in case of the Warden's tumor. Okay, so this is what you have to remember, two important etiological factors for the Warden's tumor. Okay, next moving on to the histopathological diagnosis would be, classically if you see these patients, there is the cystic space, there is lining epithelium, and there is keratin there inside. Okay, classically if you see, this is a keratin that you can see here, and the keratin has got no nuclei. Obviously it is orthokeratinized epithelium, and it is orthokeratinized OKC. Rather than that call it as OKC, the nomenclature is wrong. They should have called orthokeratinized odontogenic cyst. Actually it is not a type of OKC, it is a different it is a totally a different cyst. Okay, OOC. So please remember, in OOC there will be orthokeratinized layer, orthokeratin will be there, and secondly the patient in the if you see the cystic lining classically will have the keratohyalin granules. Keratohyalin granules will be seen classically in case of the OOC, and you don't see any kind of no basically no prominent basal cells. There is no tombstone appearance. That is called as tombstone appearance. There won't be typical tombstone appearance or picket fence appearance of the basal cells. So this is again a very important feature that you see in case of the OOC. Okay. However, in OKC you will see a classical arrangement of the basal cells, which is called as a tombstone or a picket fence appearance. Whereas in case of OOC, you don't see these tombstone, and in OOC you don't see any satellite cysts also. Remember, satellite cyst is also not a feature of the the OOC. Okay, great. Let us move on to the next question. Provide the diagnosis given from the image. So classically, if you see, everybody can easily diagnose this, that this is the, you can see here, typically hair on end appearance. Hair on end appearance. So this is a hair on end appearance, is also known as crew cut appearance. Crew cut appearance. Remember, this hair on end or crew cut appearance is typically seen in hemoglobin disorders. Particularly, you can see in both A and B. A and B, both you will see this. Okay. Particularly, it is more specific for thalassemia. It is more specific for thalassemia. Remember, usually the bone involvement is usually more specific for thalassemia. Wherever radiographic features are there, bone involvement is there, they are more in specific for this. So where both 1 and 2 means, here there is not given option 1 and 2, then you have to go with hemoglobin disorders, because in thalassemia and sickle cell anemia, what is the main problem? The main problem there is with the hemoglobin only. That is why they have given hemoglobinopathy or hemoglobin disorders. Hemoglobinopathy or hemoglobin disorders. Okay. Anti-nuclear antibody testing helps in the diagnosis of. Anti-nuclear antibodies are typically seen in SLE, systemic lupus erythematosus. In SLE, you will see anti-nuclear antibodies, particularly the anti-double stranded DNA. This is a very important MCQ. They will frequently ask you in SLE, what is the DNA that you see? What is the antibody that you will see? The antibody that you will see is anti-nuclear. I agree, but specifically within the nucleus, what is the target? Double-stranded DNA. Double-stranded DNA. Okay, there are other antibodies also, like anti-Smith, and you also see anti-mitochondrial. All those are there, but remember, specifically in SLE, anti-double-stranded DNA, 70 to 80% of the times, this will be the anti-nuclear antibody. Anti-double-stranded DNA will be the most common anti-nuclear antibody that you will see in case of the SLE patients. Okay, great. Now moving on to the next question. Diagnosis and treatment of the lesion would be, in this image they have classically given here. If you can see this image, there is a lesion here. All of you can see that easily. So this is a wrinkled lesion. Surface is wrinkled. Surface is pigmented. Surface is pigmented. Okay. So typically the patient keeps the tobacco in this region. This is a tobacco pouch keratosis. Diagnose this first, that it is a tobacco pouch keratosis. It is not leukoplakia. What should be the treatment for these patients? Treatment of these patients is all ABCD. All ABCD. So classically it will be option 2. What is ABCD? You have to do scaling in these patients. Yes, you have to ask the patient to do the mouthwash and oral hygiene. Tobacco counseling should be done. You should motivate the patient to quit the tobacco. You should motivate the patient to quit the tobacco. Observation and follow-up should be done. Okay, so classically 1 plus all 4. So 1 plus all 4 is nothing but your this one. It is not a leukoplakia. Please remember, the patch that is given there is not a leukoplakia. Leukoplakia is whitish patch, whereas tobacco pouch keratosis, which is not a pre-malignant. Please remember, tobacco pouch keratosis is not pre-malignant. It is just a wrinkled pigmented surface, and you have to remember that this it can be treated usually mainly by asking or motivating the patient to quit the tobacco chewing. To quit the tobacco chewing. Okay, bite mark identification is done by location of the bite, intercanine width, measurement of central incisors, depth of bite marks, location. The most important here, you have to identify by mainly the location of the bite mark. This is the simple straightforward question. Next, cutaneous melanoma of tumor size 2.1 to 4 centimeter is observed. According to TNM staging, how would you categorize it? So usually 2 to 4 centimeter will come in T3 according to melanoma. If you see, and the answer is basically T3. This is again a TNM staging of melanoma. Okay, but a question was asked. Actually, this comes in general surgery. Usually we see TNM staging of the oral cancers. In general surgery, they will teach you even the TNM staging of the melanoma also. So please remember, oral melanomas are always aggressive than the skin melanomas, because oral melanomas usually start with a stage 3. There is no oral melanoma stage 1 or oral melanoma stage 2. Always all oral melanomas means stage 3, stage 4. Stage 3, stage 4. So here in the question they have asked about the size of the tumor, that is 2.1 to 4 centimeter. Classically it is T3. Okay, next question. Yeah, 1 second guys. Yes. Cleidocranial dysostosis is characterized by all large anterior fontanelles, yes. Large frontal sinus, no. Absence of clavicle, delayed eruption of teeth. Classically, remember, large frontal sinus is not a feature of the cleidocranial disorder. Cleidocranial dysostosis is also known as Mary Sentence disease. It is also known as Mary Sentence disease. In this condition, basically, fontanelle will be large, and typically the patient will have absence of clavicle, that is why cleidocranial, and there will be delayed eruption of the permanent teeth. Why? Because the deciduous teeth will be over retained. As the deciduous teeth are over retained, the permanent teeth eruption will be delayed. And along with that, the most important oral manifestation or the radiographic manifestation you should know is multiple supernumerary teeth are seen in case of the cleidocranial disorder. Because of this, the multiple supernumerary teeth, you tend to see the multiple dentigerous cyst. You tend to see multiple dentigerous cyst in case of the cleidocranial disorder. You tend to see in case of cleidocranial disorder. Okay. Right. Now, moving on to the next question here. The Gary's osteomyelitis, which is a true statement among the following. What is a true statement among the following about Gary's osteomyelitis? So basically, the Gary's osteomyelitis is the which is true is a type of osteomyelitis that you see in case of a posterior mandible. Specifically, children and young adults are affected. So here the question they are asking is which is true statement. Yes, that is a true statement here. Gary's osteomyelitis is caused by the staphylococcus. No, Gary's osteomyelitis is not caused by staphylococcus. In fact, it is caused by other organisms like actinomyces and other things. Moth-eaten appearance. No, moth-eaten appearance is not a feature of the Gary's osteomyelitis. In Gary's osteomyelitis, you will see onion skin appearance. Because what happens in Gary's osteomyelitis is there is periostitis. So in Gary's osteomyelitis, you will see periostitis. Because of that, the periosteum is deposited one over the other. That is called as onion skin appearance or onion peel appearance. it affects immunocompromised patient. No, it has got nothing to do with the immunocompromised patients. Gary's osteomyelitis. So children and young adults are affected in case of Gary's osteomyelitis. That is the most important one. Okay. A 9-month child is brought to the clinic with a chief complaint of multiple painful oral ulcers. Child is also reported to have high grade fever. High grade fever. So the question only says that high grade. So high grade fever is there. What will be the provincial diagnosis? Remember, high grade fever means always viral infections. Particularly viral infections, if you see, herpes is the one which was classically associated with high grade fever. Herpangina, varicella, that is chickenpox, and they are not associated with high grade fever. But multiple oral ulcers with a high grade fever is a classical feature of herpetic gingivostomatitis. Herpetic gingivostomatitis. Okay. Moving on to the next question here. 1 second, guys. Sorry. Yeah. What is the diagnosis in this patient? If you see classically, there is a very simple, you can see image where the basically the you can see that the union of the central incisor and the lateral incisor, classically that is a fusion. This is nothing but a fusion. This is nothing but fusion. What is the condition seen below? Patient has deviation of the chin to the left side. Classically, if you see in this patient, there is a right mandibular hyperplasia in this patient. You can see here, classically, there will be deviation of the chin in these patients to the left side. So obviously, right side will be involved. And remember, it is not condylar hyperplasia, rather than it is the hemimandibular hyperplasia. Okay, condylar hyperplasia will have other features that you can see it on the this one. Here, classically, this is a case of a right mandibular hyperplasia. Which of the following which cannot be differential diagnosis basically in the following case of scenario? So if you can see classically, there is a cystic lesion. Okay, there is radiolucent lesion classically, and there is associated with the mandible. The option that is given is OKC, dentigerous cyst, ameloblastoma. Yes, all can be seen. Infection from posterior tooth, no, you don't see in case of such a infection from the posterior. See such typical or such classical radiographic features. So this is again a classical radiolucent C that you can see in case of the these are any of these first 2-3 options. Okay, so I hope all of you have understood this. This session was beneficial for you people. Yeah, I hope this session was beneficial for all of you. This was a quick revision. This was a very quick revision session of 50 minutes where we have taken all the important points, important discussion about the MCQs, previous MCQs of the INICET. Okay, so there are many more this one sessions. We will have such sessions, the previous year question paper, and definitely in INICET, all of us know trend is usually they ask some of the previous year questions. So we should be definitely be aware of the previous year questions. Okay. Thank you so much for your patient listening, all of you, and for your active participation in the particular, which can be easily reflected. You can see, I can easily see that in your chat box, your all of yours active participation. Okay. Thank you so much.